Good morning. Thank you, Scott, for the introduction and the invitation. Good morning, everyone. I think probably a lot of faculties from different around the world, and I'm same thing, from China, 33 years ago, moved to United States, and I've been in the United States for 33 years. This is my third trip to Qatar, and really impressive. Every year have something change, And I heard about the Aspetar Hospital quite a lot while I was working in the HSS, so today is a great opportunity for me to exchange my experience and my academic, view, and with our colleague here. So let me see where's my. So regarding, so today I'd like to have my talk on the sports neurology, which is a little bit rare neurology topics because in neurology people most talkers focus on stroke, talking about neurodegenerative changes. Because my experience for the past 20 years at the Hospital for Special Surgery, I like to focus on the sports neurology. But sports injury for neurology mainly divided into two categories. One is the central nervous system injury, which is mainly talk about the brain injury. But this trip, and I will probably more focus on the peripheral nervous system. So in other words, the peripheral nervous system is a big category and involving the sports injury. So in HSS, we're dealing with sports injury patient. All the hospital surgeons were sending to patient, especially confusing case, whether they are neurology involved, the nerve impinged or not, or nothing to do with the nerve. So I'm dealing with this sports injury cases every day for the 20 years. So today I'd like to really focus on the most common injury to the sports field, and the mainly is in the neck, shoulder, and upper arm. Of course, the sports injury also can affect the knee, hip, could cause the peripheral nerve damage in the lower extremity. So, but today I'm trying to focus here is mainly and talking about the neck, shoulder, and upper arm. That's why my talk will be focused on the entrapment neuropathy in the shoulder or proximal arm. So the most common injury to the shoulder and neck area actually is the brachial plexopathy, also called the brachial neuropathy. I'm sure in the medical school you guys remember all the structure of the brachial plexus, and the brachial plexus from C5 nerve root all the way to T1 nerve root, and then they divide it into three trunks: upper trunk, middle trunk, and the low trunk. And then the further extended were form the lateral cord, posterior cord, and the medial cord. So each trunk, each cord, and then they came out different type of the nerve. So as a neurologist, we have to remember all the nerve, individual nerve, where they came from, which trunk, which cord. So for me, and I naturally memorized all the stuff. Of course, orthopedic surgeon don't have to remember all these details, but I think some key features got to be remembered. For example, the long thoracic nerve from C5 to C7 actually take off before the formation of the brachial plexus. So the long thoracic nerve, and also the first nerve branch take off from the brachial plexus actually is the dorsal scapular nerve, and then they innervate the rhomboid muscle and the levator of the spadius. So this the dorsal scapular nerve is the first branch of the nerve take off from the brachial plexus. So of course, this lecture, you guys just know this is a very complex structure of the nerve, and then on the other hand, as a neurologist specialized this field, and we should remember all these details, branches. And also the brachial plexus formed from C5 to T1 nerve root, and then they came out from a special structure, basically the scalene triangle. And then they have two muscles mainly sandwiched all the nerve from the median and anterior scalene muscles. So all the nerve came out and then formed the brachial plexus. So the bottom is the clavicle. the clavicle, and it turns out that the brachial plexus will further extend and then travel with the subclavian artery and the vein together under the clavicle and above the first cervical rib. So this area, in this area also is one of the most common area to be impinged if you have an injury. This is called the thoracic outlet, region. So the nerve injury, the most common is actually do you have a point here?
There is one up there.
Let me see. Point. Maybe that's the one. Oh, yeah. So it's two locations. The brachial plexus is very easy to get injured. One is in the scalene triangle, and then the second one is the thoracic outlet, basically under the clavicle above the first rib. So the brachial plexopathy can cause by different type of causes. And then here we like to emphasize the major one is talk about the major injury. The people have a motorcycle collisions. When they fell down, we see so many cases of people fell down and extend the neck and pulling down the shoulder and then really injured brachial plexus. Falls, motor vehicle accident, knife injury, or gun wounds. And then another thing is in the shoulder injury. It's in the sports, they have a lot of sports shoulder injury. And then, for example, fracture dislocation of the shoulder is one of the most common one. And the fracture of the clavicle associated with the bone fragment, or sometimes it can also have a underlying hematoma to compress on the brachial plexus. And then there's another chronic version is the callus formation at the healed clavicle fracture site may cause chronic compression. Basically, the callus compress on the brachial plexus and induce brachial plexopathy. And in the United States, we do the American football, so involving lots of neck and shoulder injury. The famous one called the stingers and burners. And the stingers, burners usually is the injury to the neck and shoulder and cause a temporary bruise of the nerve root and the brachial plexus. So the athletes usually complain about significant burning pain in the shoulder, neck, and then they extending to the arm and the hand. But this phenomenon usually is temporary, and then the symptoms usually last several hours, will resolve spontaneously. So you were heard about this special terminology, stingers and burners. Intraoperative brachial plexus injury in the special position of generalized anesthesia, even you talk about sports injury, you do a surgery and the patient came out and have the brachial plexus damage. So during the surgery in a certain position can induce the brachial plexopathy. And in the open heart bypass surgery, almost 5% of patients can develop brachial plexopathy because they extend the neck to one side and also pull the arm, out, and then the clavicle compress on the brachial plexus is frequently induce a low trunk brachial plexopathy. It's about 5% of the case. Another common case you guys probably will see, like at HSS, each year I will see 1 to 2 cases, is after the scalene nerve block during the surgery, when they're waking up and the patient develops brachial plexus. So frequently we get MR scan the brachial plexus and there's no hematoma. But the exact mechanism we're not really sure. Think it's the anesthesia medication. Some cases is very sensitive and then develop the brachial plexopathy. And usually this type of case, and the recovery is pretty slow. It can take a whole year to recover. And then another type of differential diagnosis of the malignant tumor is the epic tumor of the lung can affect the brachial plexus, and the lymphoma can cause the brachial plexus nerve damage. And then there's another type of the brachial plexus damage is, for example, patient had tumor resect, had the chemotherapy and the radiation therapy. However, after 2-3 years later, patient developed the brachial plexus. And it turns out it's called the post-radiation induced brachial plexopathy. It's not recurrent tumor-induced. And then there's a very rare form brachial plexus called hereditary brachial plexus. During my 20 years of practice, we only see one case of hereditary brachial plexopathy. And then there's one case sometimes we're very easy to confuse about injury. The brachial plexus inflammation, we call it acute brachial plexopathy, also called acute brachial neuritis. There's another terminology we call the personage Turner syndrome. Basically, this type of neuropathy, people can have a little injury to the shoulder, and then they complain saying that they suddenly developed severe shoulder pain, and then quickly, and then develop the tingling, numbness in the arm, shoulder, and then develop the weakness. Turns out it's a brachial plexopathy injury related to the upper respiratory infection. So during the differential diagnosis, we should be aware, so this is usually has nothing to do with the brachial plexus injury. So the brachial plexus injury, I like to talk about the pathophysiology, condition. And the most common is the neck will have extension, and then the shoulder pulling down, and then basically stretch the brachial plexus. So then the most common type of the injury is a nerve root avulsion. The nerve root pulled away from the spinal cord. That's the most serious type, called a nerve root avulsion. The most common type is a stretch injury, also called the neuropracture of the nerve. Basically stretch the nerve fibers. And then there's a third one, is a ruptured individual nerve of the brachial plexus. So this is the most common type of the injury of the brachial plexus to the nerve. So initially I mentioned that there's a brachial plexus divided into several trunks, upper trunk, middle trunk, low trunk, and then distal become the cord, the lateral cord, the posterior cord, and then low cord. So now the issue is here, for example, the motorcycle accident, and the most common is affect the upper trunk. Upper trunk basically is from the C5, C6, and C7. And then when they fell down, you can see the neck will be usually extend to the upside, and then the shoulder will pull down. That's the motorcycle accident. And then they can cause the nerve root avulsion, or can cause nerve root rupture, or cause the neuropracture. Basically is a stretch injury. There's another type is mainly affected lower trunk. Is the people trying to cut the tree or go to work in the house. Trying to change the shingles, etc. So when they fell down, they pulled the arm and they can injure the low trunk of the brachial plexus. So mainly will be from the C7 to T1 level. Same thing, they can induce nerve root avulsion, neuropracture, or rupture of the nerve. There's another type is there's another very severe type, and we saw during the car accident, called the pan plexus palsy injury. So basically affected all the brachial plexus. So the patient coming and then arm is not moving at all, or maybe have a minimal finger movement. We call the pan brachial plexus palsy injury. And also there's another name called the flail limp. That's usually involving a major injury to the shoulder and neck. So besides I talk about the acute injury to the brachial plexus, I also like to switch gear to talk about some case as a chronic brachial plexus nerve injury, and then frequently relate to the sports injury. And we recently found this has become more and more, because in the old days we just have a lot of misdiagnosis on not really understand the thoracic outlet syndrome. So I think recently 5 to 7 years, thoracic outlet syndrome become a more popular diagnosis. So this is why I like to give it a more introduction into the thoracic outlet syndrome, especially related to the sports injury. So usually this thoracic outlet syndrome, it's not immediately, clinical symptoms presentation. Usually after injury, and then gradually the patient develops the classical thoracic outlet syndrome. So the thoracic outlet syndrome, the definition is only affecting the thoracic outlet. So we're not involved in the cervical spine pathology. So first of all, you always want to exclude the cervical spine issue. So you get an MR scan, exclude the cervical spine issue. Then the second is they usually will compress on either blood vessels or nerve in the space between the collarbone and the first rib. So basically, that's the space. The first rib, this is the clavicle, and then this is the rib, and then the nerve, subclavian artery, and the vein, they all went through this area we call the thoracic outlet syndrome. So again, I mentioned to you, we always have to exclude the cervical spine pathology. But sometimes it's hard. You saw the case, patient have a little bit cervical spine disc herniation, C5, C6 on the right side, and then patient have all the clinical symptoms seems not consistent with the distribution of the C5, C6. So that kind of case, then you need to consider whether patient have a thoracic outlet syndrome. So thoracic outlet syndrome frequently involve the physical trauma to the thoracic area, shoulder, neck, and the most common is the car accident and the repetitive injury from the sports or job. And some patient can have an extra rib, we call the cervical rib. And in some cases it's idiopathic. We never can find the cause. So the thoracic outlet syndrome actually have three types. One is only affect the artery, we call the arterial TOS. Second is a venous TOS, and third one is the neurogenic TOS. That's the most common type. Then talk about, besides the brachial plexopathy, I also want to re-emphasize there's one type of the brachial plexopathy, nothing to do with injury, but sometimes we're confused by the injury. The patient come in to talk to the shoulder surgeon and say, I have a severe acute onset pain. Usually it's a very, very severe pain in the shoulder or shoulder scapular area, and then develop pain symptoms, frequently associated with the upper respiratory viral infection. And then they usually affect in the serratus anterior muscle, deltoid, and both spinatus muscle, and then followed by biceps and the triceps. So when you examine the patient clinically and the EMG suggests lesion is multifocal, they usually not only affect one trunk, they affect the multiple trunk or the different cord. And so that's clinical, and EMG suggests the multifocal findings. So clinically, what's the most common presentation from a brachial plexopathy? And then frequently patient will develop the weakness or numbness, loss of sensation, loss of movement, and pain. So then you say, wait a second, say, how to dissociate with the cervical spine issue? Because cervical spine actually is more common than the brachial plexopathy injury. So the weakness usually the distribution is not the classical, let's say C6 or C7 mild tone. Because if you have a C5 nerve root damage, you know which muscle were affected. But the brachial plexopathy weakness usually is multifocal. So they're not only involved in the one nerve root. They frequently have the numbness or loss of sensation. Remember the brachial plexus nerve and that consists with motor and sensory. So they frequently have a loss sensation. So then the loss sensation is not the distribution of each nerve root dermatome. For example, the C6 nerve root dermatome is from the lateral aspect all the way down to the right thumb. But for the brachial plexus sensory loss, for example, the leg nerve loss is only decrease the sensation in the lateral aspect, the right forearm. So we're not affect the thumb. So in other words, the distribution of the weakness, the sensation change will be not consistent with the dermatome or myotome from the cervical spine injury, nerve root injury. So in the clinically, how to evaluate brachial plexopathy? And first of all, as a neurologist, physical history, physical examination is extremely important. I mentioned to you the weakness, sensory loss is not consistent with the classical reticulopathy symptoms, including dermatome and myotone. And so the physical examination is very important. Second, the image study. And the third one, we frequently use nerve conduction EMG study to help us to get a clear diagnosis or localized lesion. So we talk about the image study, and then the most common one we use the X-ray. Because when you have the injury to the neck or shoulder, you want to see whether the shoulder have a dislocation, have a fracture, or clavicle have a fracture. So the X-ray is quite important. Second, we get a CT or MR scan. But again, we always, when we do the brachial plexus investigation, we always will look at the cervical spine as well to make sure it's not from the cervical spine, or there's an overlapping issue, because when they have an injury to the neck or shoulder, they frequently affect the shoulder or affect the brachial plexus. So we get an MR scan, CT scan, we frequently will cover the cervical spine and brachial plexus. And the third one is sometimes we use the CT monogram to further define the patient whether have a nerve root erosion. So this is a MR scan and then CT monogram to illustrate the brachial plexus nerve injury. For example, here the T2 signal increase in the brachial plexus clearly indicated there's edema in the brachial plexus area, had a serious injury. This is the lateral section of the MR scan and showed the increased T2 signal in the brachial plexus area. So this series of pictures, you will see the CT monogram and also see the MR scan. You will see this phenomenon. It's a classical phenomenon of the nerve root erosion. Also, we also call that pseudo-meningeal cell. And you can see that's like a bump containing fluid. And then this is coronal section, the CT monogram and the MR scan. And that's the classical pathology finding for the nerve root erosion. So basically, MR scan or CT monogram can give you a clear diagnosis whether the patient have a nerve root erosion or not. The second one is we talk about thoracic outlet syndrome. The diagnosis is very hard, sometimes confusing, either way underdiagnosis or overdiagnosis. So the radiologist, so many radiologists, they only want to do the TOS series. They call it the TLS series. Because now there's several radiologists in the country that are really, really fussy about the diagnosis by use the radiology MR scan. But on the other hand, they again re-emphasize to diagnose the thoracic outlet syndrome is not totally depends on the MR scan. Because the MR scan in some cases could be very classical, you can see the objective finding. But we saw so many cases, and we believe it's a thoracic outlet syndrome, but MR scan could be negative. So in other words, to diagnose a thoracic outlet syndrome, to the end, you need a clinical diagnosis. But the MR scan will be a plus to help you to get diagnosis. But again, even if it's negative, you have to really figure out whether the patient could have a thoracic outlet syndrome. So the thoracic outlet syndrome, when they do, they have a special protocol. One is the neutral position, and the second is they lift the arm, we call the amber body position, like a abduct and exrotate the arm and hand, and then usually it's up to 130 degree. That's a standard protocol. So when they do the MR scan, they usually not only look at the nerve, they also will do the arteriogram and the venogram at the same time in two positions, neutral position and the amber's position. So now become very common. So when we order an MR scan, we always will put it in, say, thoracic outlet syndrome special study. So the technician know the exact protocol how to do all these three. So looking to the literature-wise, in the radiology in 2003, that's a big study, and then came out some relatively convincing data. So they studied that 54 4 patients with presumed diagnosis, clinical suspicious of thoracic outlet syndrome. Of course, they exclude the neck pathology. And then they also invite 35 volunteers without thoracic outlet syndrome symptoms. So they use So they have their patient in 2 positions, neutral position and amber position. Amber position 130 degree. So they compare the patients and volunteers. They use 2 criteria, and the one criteria, the subclavicle muscle thickness, found that there's 2 groups, there's no major difference. However, the minimal costoclavicle distance, so basically the distance between the clavicle and the first rib, and in the amber position, the patient was suspicious has the thoracic outlet syndrome, and then the distance is only 8.72 millimeter. The volunteer group is 11.47, so there's a significant difference between the patient have the thoracic outlet syndrome versus the patient without thoracic outlet syndrome. So now they frequently use the distance of costoclavicle gap or interval to diagnose whether this patient have the brachial plexopathy consistent with the thoracic outlet syndrome. So here I'd like to show you a few cases which done by Dr. Scott Wander in San Francisco. So turns out that this case is a 52-year-old gentleman have a chronic right hand numbness. And then cervical spine MR scan is completely normal. So they suspicious whether this patient could have a thoracic outlet syndrome. So this is the natural position, and then they measure the costoclavicle interval. And from this is first the clavicle and the first rib, and they measure the brachial plexus. This is the amber position, and they found the costoclavicle interval in neutral position and amber position. In this case, there's no significant difference. So there's another case. It's a 25-year-old man with numbness in the 4th and 5th digital of the right hand, and after the UCL construction 4 months ago. And then the patient have the tingling numbness in the 4th fingers, the suspicious of thoracic outlet syndrome. So in this case, you can see this costoclavicle distance. This is about, I think it's, let me see, 30 millimeter. And then when they, in the amber position, and then they found only 9 millimeter. So they are very convinced this case the brachial plexus is compressed, so they can get a clinically and a radiographic diagnosis of a thoracic outlet syndrome. So there's another case show you a patient have additional cervical rib, called the cervical rib, and which can compress on the brachial plexus. And then second, at the same time, this case, and then the patient have a very narrow clavicle and first rib space. So this is the cervical rib, and then the thickening of the brachial plexus. And then here's on the axial cuts and the cervical rib, clavicle, and then brachial plexus is compressed. So this is the case to compare. It's the same case. We look at the normal patient. Normal patient, you can see the brachial plexus, the clavicle is here, and then the first rib is here. And then the brachial plexus, the thickening is that degree, that size. That's the normal size. For the patient, we just showed have the cervical rib, and then we ask the patient lift the arm in the amber position. And then you can see this is the clavicle and the first rib. That's the first rib. And you can see the brachial plexus. See, this is so thick, and then this is so narrow. And so basically illustrate compression of the brachial plexus by the first rib and clavicle. The spaces become small. So by the conclusion, and meanwhile, they also did the arteriogram and found the subclavian artery had a compression, focal compression. So this case, they conclude, this patient, they conclude by image study, compression of the brachial plexus between the clavicle and the small cervical rib. The second is compression of the brachial plexus between the clavicle and the normal first rib. Number three, they also have the evidence compression of the distal subclavial artery. So all this convincing plus the convincing MR scan findings plus the clinical symptoms and neurology examination. So this patient clearly have a thoracic outlet syndrome. This patient actually went to the surgery and then had the cervical rib removed, and also they had a decompression, and then the symptoms is completely recovered afterwards. So we talk about the brachial plexus diagnosis versus the clinically physical examination, and then we talk about the brachial plexus MR scan, and then we talk about the electrophysiology study, which actually is very important because I received so many cases that orthopedic surgeon want us to do the EMG to define where's the nerve damage, what type of nerve damage, where is the nerve damage, and what's the outcome, and what's the recovery. So first of all, the nerve conduction EMG study can confirm the physical examination. So this is from cervical spine or from brachial plexus. If a brachial plexus, whether from individual nerve, branch, nerve injury, or involving multiple trunk, and then they can anatomically localized, and sometimes also can distinguish the overlapping condition. Some patient, turns out it could be no nerve damage, but look like a classical, brachial plexopathy. So the EMG, even negative for you, is very important to dissociate whether this is a nerve damage or not. And then some people have the shoulder weakness. It turns out it could be the central nervous system damage, spinal cord damage. EMG study will be normal. So distinguish the overlapping condition. EMG is extremely important. So most of the case for the brachial plexus injury, we do a EMG about 3 to 4 weeks after the injury. So we have a baseline there, and then after 2 to 3 months, we'll repeat the EMG to monitor the axonal whether they have evidence of regeneration. So here I give you an example. The EMG study, what's the difference from this classical cervical spine reticulopathy? So cervical spine reticulopathy, usually the pattern, the motor unit amplitude could be dropped a little bit. And then when you do the needle EMG, you will see classical specific mild tone. Let's say C5 nerve root damage. Classically, the muscle innervated by the C5 nerve root will be active denervation. However, the brachial plexus is a very complex structure. They have the motor and sensory components. So they frequently on the nerve conduction study, you find there's not only the motor nerve can be changed, and also frequently have a sensory nerve change. So for example, this case, on the left side, the median ulnar, and then the amplitude is fine, their distal latency is fine, and the conduction velocity is all in normal limit. They did the median and ulnar F wave, also is normal. Then if you look the sensory nerve, the median nerve, they compare with the right and the left. So this patient, the pathologist on the left side, you can see the difference. The median nerve and the sensory on the right side is 33, on the left side is 22. And then that's the ulnar nerve. And then you can see the radial nerve, 39 on the right side. This is only have 16 on the left side. And then lateral antibranchial cutaneous nerve, and on the right side is 14. And on the left side is absent. That's nerve conduction. It's a very classical case of the brachial plexopathy. However, brachial plexopathy, you cannot diagnose it by only a nerve conduction study. That's only help you. So the needle EMG becomes very important. For example, this case, you can see multiple muscle had active denervation. For example, the deltoid muscles, biceps muscles, brachioradialis, inferior spinatus, triceps, left pronatal tears. So all this is have a multiple. If you're looking for the mild tone, deltoid muscle, inferior spinal column is C5 nerve root, biceps is C6, triceps is C7, and then pronator teres is C6. So in other words, they not only affect one nerve root. If it's a classical reticulopathy, you will see a classical individual nerve root damage. But this is a patching. They affect several nerve root. So combining with the nerve conduction, have the sensory loss, and plus the multi-nerve root type of involvement, and plus your clinical diagnosis, and then this is most likely is a brachial plexopathy rather than a cervical spinal reticulopathy. So now we talk about the brachial plexus injury and what type of treatment we have. Of course, here I'm sure you guys have a lot of stayed out of the facility to do the non-surgical treatment, physical therapy, pain management. Pain management, and usually we use all kinds of the neuropathic pain medication. Injection nerve block, we don't use that often, even though one of our colleagues, sometimes they do the nerve block. And then also, sometimes we use the EPAT and ultrasound to loosen up all the muscle and tendon in the shoulder area. We use quite a lot. Acupuncture sometimes also helps. And then neurologists, we always need to really monitor the patient. So every 2 to 3 months, we examine the patient. And then in order to assess the nerve recovery, sometimes we do in 3 to 4 months, we repeat the EMG and to see is there any sign of recovery. So some cases, the patient, the brachial plexus injury ends up to the surgery. And in our hospital, and mainly the surgeon to do the brachial plexus repair surgery is Dr. Scott Wolf, and his expertise, especially in the nerve transfer. So what's the indication for brachial plexus nerve surgical treatment? So the indication, the nerve fail to recover, or they fail to recover enough to restore the hand on the arm function. So that type of patient, after 6 months, 8 months, they not recover well, and that indicate for surgical intervention. There's another one, the MR scan, if you see the nerve root erosion or rupture of the nerve, so you know they're not going to recover that well. So they have a different type of the nerve transplant and procedures. Also, in the old days, nerve root erosion basically is a permanent nerve damage, but now they had some new surgical procedure and they have some good clinical results for the nerve root erosion. And then the last one is the thoracic outlet syndrome. Again, most of the cases of thoracic outlet syndrome, we use the conservative treatment, such as physical therapy, pain management. But very, very few cases, the patient unfortunately have to go to their surgical decompression surgery. Actually, for my experience, I have 3 patients finally went to the surgery for the thoracic outlet syndrome without evidence of cervical rip after the injury. Turns out the 3 patients, they all came out with very, very good results. Initially, we never sent a patient. Just recently, 5 years, we sent 3 patients. Good results is very well. And then consideration for the surgery, and then usually people have to know the recovery. Even after surgery, the recovery could be take a long, long time, take about years to recover. And also the surgeons are very anxious to pick up the surgical candidate, because some patients have a very high expectation of the surgeries. When I have a surgery, we will fully recover. It's not realistic. So we have to explain to the patient about unrealistic expectation. Second, the comorbid conditions, because a lot of patients already have a really contracted shoulder and the neck, and you cannot do surgery, it's not going to have a good outcome. Some people have a major spinal cord injury, some people have a brain injury, so we have to select certain patients have a very good outcome and to do surgery. So the surgery has been, the surgery, you have the nerve repair, nerve graft, and in our hospital, mainly they focus on the nerve transfer, and also tendon transfer is one of the technique for the surgical treatment. So, however, the detailed surgery, because I'm not an expertise in surgery, so I'm not going to discuss. Scott Wolf will be the right person to discuss. And then besides that, we talk about that the overall brachial plexopathy injury, and then we also talk about the several individual nerve injury. Actually, they arise from the brachial plexus. For example, there's musculocutaneous neuropathy, and then they frequently involving the upper arm or shoulder injury, because this nerve came out, innervate 3 muscles: coracobrachialis, biceps, and the brachialis. So 3 muscles. And then they also have extension of the sensory components called the lateral antebrachial cutaneous nerve. They innervate the sensation in the lateral aspect of the the forearm. So on the examination, you will see if they have a serious injury to the musculocutaneous nerve, and then the patient have a difficult to flex the shoulder and flex the elbow, and frequently complain about that tingling numbness sensation in the lateral aspect of the forearm, and the frequent biceps reflex were dropped. So the most common one injury is proximal versus distal lesion, and dislocation of shoulder is one of the common injury to the musculocutaneous nerve. Then strenuous exercise, general anesthesia, acute brachial neuritis, and frequently associated with individual nerve, or they could be the entire brachial plexus involving the musculocutaneous nerve injury. So the treatment, the treatment of first of all, how to diagnose this. The physical examination I mentioned, they have the weakness in the flex of the shoulder and flex of the elbow. And the EMG frequently can get a very clear diagnosis. For example, they frequently will have an absence or low amplitude of the leg. Leg is the lateral antebrachial cutaneous nerve. So that sensory will be lost frequently. Second, the needle EMG, remember there's 3 muscles. The easiest muscle you can check is the biceps and the brachialis. So when you examine them, these 2 muscles have the spontaneous activity, and also the leg snap will be absent. That's the classical EMG finding. There's another type of the branch from the brachial plexus is the suprascapular nerve injury, and this injury actually is more common than the previous one, because the nerve is in the shoulder area, and frequently have the repetitive stimulation or sports or exercise can damage this suprascapular nerve. So the suprascapular nerve is from the upper trunk of the brachial plexus. They go under a transverse scapular ligament. And then that little hole we call the suprascapular notch. So if the most common one, the nerve damage is in this area, so then they will affect both branches. One branch is to the supraspinatus muscle. Another branch is affect the inferior spinatus muscle. So if you have found that both muscle affected, both muscle atrophied, it's frequently the lesion is in the suprascapular notch. Another notch is called the spinal glenoid notch. That's only affect the branch innervate the inferior spinatus muscle. So we'll spare the muscle in the supraspinatus muscle. So the suprascapular neuropathy frequently got injured from the compression injury. For example, the patient, they carry heavy bag to do hiking, and then they come in and they found how come my muscle start atrophy. So the hiking people, they frequently, because they carried a very heavy bag, and then they can call, and the frequency is affected in the suprascapular notch. So they were all the spinal glenoid notch, but the suprascapular notch is the most common area. And the traction injury, the level mainly is the transverse scapular ligament or spinal glenoid ligament, or directly trauma to the nerve. And then sports injury, the most common one, the sports injury, actually is anything over the head. So you do the tennis, swimming, volleyball, and the weightlifting people, and frequently can develop the suprascapular nerve neuropathy. And another one is, the stance. Dense people, they frequently have to do this type of the movement. They continue stretch the suprascapular nerve, and then they frequently, see the professional dancer with multiple cases and can develop that suprascapular neuropathy. And then the diagnosis of suprascapular neuropathy, and then the most common one is cause atrophy of the supraspinatus muscle and inferior spinatus muscle. Clearly, they will have a weakness to abducted arm, and also if we put the elbow against the chest wall, and then they have a hard time to exrotate it. So if you affect, as I mentioned, if we affect both muscles, so the lesion could be in the suprascapular notch or under the transverse scapular ligament. So there's a huge cyst. Actually, they affect both branch of the spinatus, supraspinatus muscle and inferior spinatus muscle, so cause muscle atrophy in both branches. And then this is an MR scan show you the suprascapular nerve, and you can see some certain part of the nerve it become constricted. This is due to the chronic compression, and then you can see the nerve is not normal continuation, rather than they have constriction in between. So then talk about treatment. Treatment, first of all, is we need to avoid precipitate activity. For example, we should not use the heavy bag, and also, for example, the sports injury people, they have to stop their special activity in order to let the nerve heal. And then physical therapy clearly is the most common one we use. And then surgical intervention, and usually the conservative treatment feels alleviate the symptoms more than 6 months. So release of the transverse scapular ligament is the most common procedure. And if you already see that on the MR scan, you see there's a cyst there, and then usually we will directly go in to get rid of the cyst. Then the recovery will be faster. And this axillary neuropathy actually is quite common for any injury to the shoulders. And even we have a lot of shoulder surgery. After shoulder surgery, patient develop the axillary neuropathy. So the shoulder surgeon frequently exchange patient with us to discuss the case with us. So the axillary neuropathy, the nerve is relatively short. It's from the posterior cord. And then they innervated 2 muscles. One muscle is the deltoid muscle, and then there's a second muscle is the tear minor. So they only innervate 2 muscles. So frequently you will see the patient have an isolated deltoid muscle atrophy and weakness. And then there's another one is they have a small branch of sensory nerve, and then they innervate on top of the deltoid muscle. So frequently patient will complain weakness of the shoulder and also numbness in the deltoid muscle area. So this is a very classical. They decrease the sensation in the deltoid muscle and have atrophy of the deltoid muscles. So because of this special structure, and then you can see the anatomical structure, the nerve came out from the quadrilateral space. So the most of injury is in that space. So for example, into the trauma, dislocation of the shoulder frequently can affect the axillary nerve. Fracture of the humerus, fracture dislocation of the shoulder, missile wound, blunt trauma without fracture or dislocation to the shoulder. Again, most common zone of injury is proximal to the quadrilateral space. So usually in that space area can affect it. And then sometimes we also see patients after the injection, and then they can damage the nerve, but usually the outcome is pretty good. And the acute branchial neuritis also can induce the isolated axillary nerve damage. So axillary neuropathy, the diagnosis I mentioned to you is isolated deltoid muscle weakness, so the patient cannot do the abduct of the upper arm, shoulder. And the EMG, you can clearly to diagnose whether this patient have an axillary neuropathy. So in other words, a lot of patients have a shoulder weakness, not necessarily is a axillary neuropathy. So EMG, yeah. So EMG study is very important for us to diagnose whether this is a axillary neuropathy. And then sometimes we also have the image study to make sure we don't have any hematoma or bone fracture compressed on the nerve. And physical therapy is the common treatment. And the surgical case, the clinical electrophysiology evidence of improvement is not improved in a certain area, surgical intervention is indicated. So best repair window is about 6 months, the 6 months window. So the last one I probably will talk just the lung thoracic neuropathy. So lung thoracic neuropathy frequently due to trauma to the neck or on the side of the chest wall, and then blown to the shoulder or lateral thoracic wall in falls, motor vehicle accident, football, basketball, or wrestling. And the surgical injury also can cause, and the general anesthesia, and then the last one is the associated with the acute brachial neuritis. So on the examination, because the lung thoracic nerve is innervate the anterior serratus muscles. So you can see classically patient have the scapular wing. So the electrophysiology study also is very important to make sure this is only affect the lung thoracic nerve. And the image study just want to make sure there's no hematoma or bone fracture. And then, so when you do the EMG study for this kind of case, it's very difficult because you don't want the needle puncture between the puncture the lung between the rib. So you always have to feel the rib, and two fingers hit the rib, and then you put a needle on top of the rib, so you can get a very clear diagnosis because you don't want to get a major injury to the lung. So finally, we talk about the treatment. The treatment is a non-surgical treatment, but take a much longer time. So we have to be patient. Usually, the patient will take about 1 to 2 years to get recovered. And then the surgical treatment, if the patient did not improve, the scapular wings stick out for more than 1 year. At least 25% do not respond to the conservative treatment, and then this type of patient need surgical intervention. Surgical intervention for the nerve transplant is not great outcome. So most people will use the tendon transplant to do the sternal head of the pectoralis major tendon to the inferior angle of the scapula reinforced with or tendon autograft. In that way, you can fix the scapular wing. So I think today I will probably start here, just covered all this brachial plexus and all the individual nerve. Because the last one is the spinal accessory nerve damage are not that common in the sports injury, rather than for the people do the lymph nodes biopsy or whatever were developed. Okay, so thank you very much for your patience to listen to all these details.
We have time for one or two quick questions.